I'm Mark Pepin. I'm an MD PhD student here at UAB School of Medicine. And this is Erin Dorman, a PA student here. And today we'll be teaching you through the HEENT exam. Now, before you enter the rooms, it's important to know that you have the proper equipment to perform this exam. So what I have with me is a tuning fork, specifically the 512 Hertz. Secondly, I have a pen light here, also a tongue depressor. And I also have an eye chart. And there's actually two types of eye charts. Notice the different sizes in the lowest font here. Maybe you can't see that from there. But it's important to read the small font, basically at the very bottom of each of these charts. One of them, so this one requires you to hold the chart at 16 inches, 16 to 18 inches. So basically at arm's length, have the patient hold it. The second one here is actually at the foot of the bed, or about 6 feet from the patient. So you yourself would hold this and ask the patient to read it. So just kind of a thing to note on what you actually have with you. The last thing here, it should actually be in the rooms, but you also have boxes of portable versions are on the wall here. So this is an ophthalmoscope. Notice the flat surface, okay? This has a light that we'll describe in a minute. The other one, more tube shaped. This is the otoscope. Okay, so make sure you don't confuse the two. This is for the ears, this is for the eyes, okay? And then there are a bunch of tips for the otoscope itself. Okay, so the first place we're going to start is arbitrarily just at the top of the head. So we'll start by inspecting the scalp. And actually, before we begin, it's important to be able to get close to the patient so you can remove their leg or the footrest. Just push it all the way into the bed. So now we can actually work closer. Now, the first thing we're doing is just inspecting the scalp. And to do that, use both of your hands to just part the hair in a number of different places. See if you can get a couple of different places inspected. And you would do that on the sides and on the back. I'm not going to do that for you. The next part is to make sure that you palpate or feel the entire head itself. And what you're doing here is you're just checking for the bony structures, making sure that there is not tenderness, that there's no prominences that you'd find suspicious or unusual, which I don't feel any of that, so we're good to continue. So that's pretty much done with the hair. Also, what you want to do is inspect for any signs of patchy hair loss or any things that you might want to take note of, depending on how the patient presents to you. Okay, so the next part we're going to do is looking at the face. We'll be inspecting the face. And to do this, what we're going to primarily look at is for symmetry, but some other things that you can look for are abnormal tics, some features that might be involuntary. But other things include how the eyes are bulging or not. Okay, so we're done inspecting the face. Next thing we'll do is just palpate a couple of areas of the face, primarily the sinuses in particular. So what I'll show you first is the frontal sinus here. It's located just above the eyes, but actually in order to feel for tenderness, what you can do is press up just underneath the eyebrows, just like this. Okay, the next part, or the next sinuses are at the maxillary level. So the maxillary bone contains these sinuses here, which can become tender. So you can press on them just in this area. All right, and then a last structure that can be optionally tested for, if indicated, is the temporal artery, the superficial temporal artery. It's located just here in the temporal region. And you can just check for strength of the beat and any signs of tenderness when you press there. Okay, so that concludes this portion of the exam. Okay, so now that we've finished inspecting and palpating the head and face, next thing we want to do is focus on the eyes. So before you actually begin checking the eye's function itself, you want to first inspect the external structures of the eye. So what we're doing is you can look for the color of the sclera, look at the eyelid shape, ensuring that it's symmetric on both sides, and also to look more at the parts of the eye that are less visible. You can pull down on the lower eyelid. Can you look up, please? Good. Now pull up. Good. Perfect. So that basically allows us to get a better look at the entire sclera itself. Okay. So next part we're going to do is check for visual acuity, and that's performed using these eye cards, as I'd already described. And so this is the one where the patient holds it at arm's length, approximately 14 inches. Okay, so before you actually do this though, you want to make sure that your patient is wearing corrective lenses if they have it. So Erin, would you please put on your glasses? Okay, and then hold this with one hand. With the other hand, could you cover your eye, one of your eyes? Good. Could you read the smallest line that you can read?
Yeah, 428,739.
Great. Okay, now could you cover the other eye? And can you read that same line backwards?
937,824.
Okay, excellent. So what Erin has just demonstrated is 20/20 vision. Now, just to interpret that a little bit, let's pretend like she had 2100 vision. Now what that means is that a normal person could read that line of font at 100 feet distance, but she can only read it at 20 feet distance. Okay, so the next component of the eye exam is checking for visual fields. And to do this, we'll be using essentially two techniques. First one is more of a crude assessment, checking what are called quadrants, and I'll show you how that works in a second. And the second one, if indicated, is a more detailed characterization of a visual deficit, if necessary. Okay, so to begin, the first thing we're going to do is basically just be checking all four quadrants. And if you can imagine a vertical axis through each eye, and then a horizontal axis, that basically creates four individual quadrants above and below from right to left. Okay, so that's really what we're trying to check in this case. And to do that, what you want to do is actually hold up your fingers in each of those four quadrants, and you can check actually two at a time. Now, what I'm going to ask you to do, Erin, is when I hold my fingers up, could you count them? Just look straight at my face. Okay. Could you tell me how many fingers I'm holding up?
3.
Good.
5.
Excellent. Okay. Now what she's done is added the total number of fingers up in each of the quadrants, 2 total, and given me the total number. Now if I noticed that she gave me, say, a 2, and I had 3 fingers up down here, you would know that the lower right quadrant had a visual deficit. Okay, and then vice versa. Okay, so once you've finished the crude assessment of visual fields, if you find something interesting and you want to characterize it further, you would then do a more specific test. Now, for this, there are actually 2 ways to do it. The first one, what Bates calls a fishbowl technique, is basically where about 2 feet away from the patient, you would then start in the periphery, so using, again, 2 quadrants, and then wiggling your fingers, ask the patient when they can start to see your fingers wiggling.
Now.
Okay? And then you would do it again.
Now.
Okay, what I'm doing is basically following this imaginary sphere around your patient, entering the field of vision that you can see. And doing so allows you to basically see at what point can they suddenly see your fingers wiggling. So, okay, so that's one way to do it. Another way is actually to check in comparison with your own vision, which I tend to prefer. But basically to do that, what you need to do is get a little bit closer to the patient, and then right in between you two, have your fingers out as far as you can and wiggle them and ask the patient, can you see my fingers?
Now.
Okay, so if they can see it when you start the assessment, that's pretty much usually indicative that there's no abnormality. But if you actually want to characterize their vision in comparison with yours, just get a little bit closer and then ask them again, can you see my fingers?
No.
Okay, at this point you would then just enter in between you, get a little bit closer.
Yes.
Okay, and do it again.
Yes.
Okay, both at the same time?
Yes.
All right. So that's how you would check all 4 quadrants of the patient's visual fields. Okay, so the last part of this particular exam is if you actually identify a problem or if you want to characterize a deficit even more, you would then cover one eye and then repeat the same test using those visual fields again. Okay, so while the patient is covering one eye, you would then cover the same eye on the same side, basically, the same side. Okay, so Erin, could you please cover your right eye? Good. I'm going to cover my left eye. And can you see my fingers wiggling?
Mm-mm.
Okay. Tell me when you can see them start.
Now.
Okay. Again.
Now.
All right. I'm going to start on the other side.
Now.
Okay. One more time.
Now.
Great. Okay. Then you just repeat this process on the other side. So at this point, we've finished the visual acuity and the visual fields. The next thing we'll check is the muscles that control the eyes, or the oculomotor activity. And to do that, what I'm going to do is just stand right in front of Erin and say, Erin, could you please look at me? Okay. Could you look at my finger now? And now just follow my finger as I move it. Okay, now what I need you to do is actually look straight at me and hold your head still, okay? Good. Now, look at my finger. Good. Could you just follow it all the way? What we're going to do is just make an H. Just follow it. Good. Now on the other side. Excellent. Okay, and when you get back to the middle, what I'm going to do is actually draw my finger towards your nose. Could you please follow it to your nose? Good. And what I was checking for there is actually to see whether the pupils constrict as they normally would, which was the case on both sides. Okay, the next part is going to be checking using our pen light. And we'll have really two tests using the pen light at this point. The first one we'll do is called the corneal light reflex. And to do that, we're just going to shine the light directly in front of Erin here. And what we're actually looking for is the reflection of the pen light on the surface of Erin's eye. More specifically, the distance from the bridge of the nose at the midline, and also making sure that they are symmetric on both sides. Okay, looks fine. The next part using the pen light is the pupillary constriction to light, and there's really two parts to this. One is when you're shining it into the eye, so that's called the direct constriction. Okay, so what I'm looking for in this case is this eye is constricting when I shine the light into it. The second part I'm looking at is the consensual reflex, or the consensual constriction in the other eye, the contralateral eye. So we then check the other side for direct and consensual. Okay, so the last part of this exam is really just two components. One is the red reflex, looking at the back of the cornea, and the other one is the ophthalmologic exam, looking at the back of the eye at the retina, both of which require you to use this device. This is the ophthalmoscope. Notice this has that flat front to it. This is the ophthalmoscope. And it has a couple of things that you should actually know before you start looking in the back of the patient's eyes. One of which is the intensity of the light. So if you can see the circular light here on my hand, this is the brightest image that it can make. The only reason you wouldn't do this is because it's uncomfortable for the patients. But on the other extreme, it's too dim for you to see the structures you're trying to identify. So somewhere in the middle is really probably the best place to start. The other part of this device that you have to be able to adjust is the focus of the lens through which you're able to look, as through here. Okay, and to do that, there are some numbers right here through this hole. And I have it here at the 0, but basically you're adjusting it according to your ability to see clearly through this eyepiece. And to do that, you can look at either the blood pressure meter, these numbers here, or if you have a watch, you can also look there and adjust these numbers until it's right in focus. Okay, so once you've established that before looking in the patient's eyes, you would then turn off the light, tell the patient you're going to turn off the light, and then do that. And then standing at just a little bit of a distance, shine the light into the patient's eyes. And you can have the patient look sort of at a distant location away from you. So that's good. And what I'm doing here is looking for essentially the red eye that occurs if you're using a flash camera. And that's just the color of the retina in the back of the eye that you're actually seeing. Okay, so once you've established that, you would then get a little bit closer, and then looking through the same eye that you were actually assessing in the patient. So in this case, I'm looking in Erin's right eye. So I'm going to use my right eye to look through the eyepiece. This is kind of important. It just helps with patient comfort because it allows you to stagger your faces when you're approaching the patient, looking in the back of their eye, so that you're not approaching the patient nose to nose. It just gives you a little bit more personal space. Okay? So before I look in the back of the eye, I'm just going to put my hand on your forehead. Helps me know where you are. And then look in the back of the eye. You would then just approach the patient a little bit until you can see the normal vasculature in the back of the eye, in the retina. And you can follow it towards the optic disc, and you can really trace some of the anatomy. And to actually help you see a little bit more, you can have your patient look up or down, left or right. So if you're looking up, I can see the top borders of the retina. If you're looking down, I can see the lower borders of the retina, and so on. So then you could repeat this on the other eye, but if you're looking into their left eye, you use your left eye through the eyepiece. Okay, so now that we're done with the eye exam, next part is the ears. And the first thing we're going to do is just inspect the external ear itself. So you can just pull the hair back and just inspect the external ear for any signs of inflammation. You can even get a superficial look in through the canal to see whether there might be an obstruction. But you can then start palpating the external ear structures, basically assessing for any signs of tenderness, which can occur if there is an infection of the external ear. So even pulling up, retracting outward can cause pain or discomfort to the patient if there is an infection. Okay, so once you've then palpated the external ear, what we'll now do is use the otoscope to do visual inspection through the ear canal itself. And this is a wall-mounted otoscope. You guys have those wireless ones with a battery. They work the same way. But in this case, I'll just ask the patient to hold the cord so that it's not pulling against me. And there is, again, just with the ophthalmoscope, the ability to adjust the brightness of the light. Okay, so in this case, just kind of turn it all the way up just so you can see what you're doing. It shouldn't cause discomfort to the patient if it's bright in this case. But once you have that, I prefer to hold it almost like a pencil, because when I do this, it allows me to rest the pinky side of my palm against the patient's face, the side of her face, making sure that I'm not going to go too far in or adjust in a way that would cause damage or just discomfort. Okay, so when we're going to insert the otoscope into the ear canal, I'm going to basically use upward traction on the outside of the ear to align the ear canal with that of this otoscope's tube. Then inserting it, looking into the eyepiece, you can then see the eardrum itself. Okay, and when you are ready to remove the otoscope from the ear canal, make sure that you're actually looking through the otoscope, because doing this, you can actually see the wall of the ear canal and basically assess for signs of inflammation. Okay, so now that we're done with the otoscope and examining the external structures, we'll actually just test hearing. The first thing we want to do is just test general hearing. So you can do it a couple of ways. I prefer to just use my fingers and friction between them to just put on either side of the patient. You can ask them to close their eyes, you're removing the visual cues, and you just say, could you please just tell me what side you hear my fingers rubbing?
This one.
Good.
This one.
Good.
Both.
Perfect. Okay, so if you suspect that there is a discrepancy in hearing from your patient, you would then want to characterize it a little bit more, and specifically to determine whether it's more likely sensorineural hearing loss or what's called conductive hearing loss. And to do that, we have two special tests. The first one I'll show you is the Weber test. And using a 512 hertz or 256 hertz tuning fork, you would then ring it using your fingers like this, or you could just lightly tap it on something hard, the desk or the table or something. Once you have it ringing, you place it immediately on top of the patient's head like this, and then you could ask them if they can hear it.
Yes.
Okay. And if they can hear it, you can ask them, do you hear it the same on both sides, or is it more on one?
The same.
Okay. So that means that Erin's hearing is equal on both sides, but if you find that your patient says, no, I hear it louder, say on her right side, it could either be actually conductive hearing loss on her right side, actually, or it could also be sensorineural hearing loss on the opposite side, the side that hears it less. Okay, so there's two possible explanations for that. To characterize it even more, we want to do this additional test called the Rene test, to basically on both sides to see whether it is sensorineural on that side or conductive hearing loss on this side. Okay, so to show you that, Erin, could you just look to your left shoulder? What we want to do is, again, ring this 512 tuning fork and place it this time on the back of the ear. It's called the mastoid process. It's this bony part in the back of the ear. And so I'll do that here. Can you hear the ringing?
Yes.
Okay. Can you tell me when you can no longer hear it?
Now.
Okay. How about now?
Yes, I can hear it.
Great. Okay, so what I did was I first asked her when she could stop hearing it using bone conduction through the mastoid process. When she could no longer hear it, I then tried using air conduction of this sound, which is usually more effective, and she could still hear it, indicating that air conduction through the tympanic membrane is effectively transmitting sound as it should. So this basically rules out conductive hearing loss on her right side. I would then do the same technique over on the other side to determine whether it is sensory neural hearing loss, like we would have suspected. Okay, so now we're done examining the head, the eyes, and the ears next to the nose. So for this one, we're going to use, again, the otoscope when we're examining inside of the nose through each nair. But before you do that, you want to first inspect the external parts of the nose. And to do this, we're pretty much just looking for symmetry or any external abnormalities that are obvious, which they are not in this case. Okay, so we're good to go. Look through the nairs. And you can actually use the same tips in theory from the ears. There's no risk of doing that. But I mean, these are disposable, so I'm just changing it out. But to do the actual inspection yourself, thanks. You can have the patient look up, and this just sort of gives you a better read on the inside of the nose. And then you can just insert it into each of the nairs, avoiding the septum of the nose, the sort of part right at the midline. Okay, and once you've looked all the way through, top to bottom, you would then inspect the other side, the other nair itself. Okay, so now that we're done with the nose, we'll then start with the mouth. And to do that, I have with me a tongue depressor, which is sealed. It's fully enclosed. So when you open it, though, make sure that you're only opening one side, and that you're only touching one side of it. So I've opened one side, just with this one finger, or these two fingers, I'm holding just one side of it, not touching the other, because that's where we actually insert it into the patient's mouth. Okay, so when we do this, here, Erin, could you please open your mouth? Good. And I'm using my pen light here just to be able to see the structures on the inside of the mouth. And you can use your tongue depressor to open the side of the cheek, look along the side of the teeth on either side, again on the other side here. And also, could you lift up your tongue, please? Good. What we're looking for, ulcers, anything on the teeth. We're not dentists per se, but we are looking for obvious signs of an infection or something to worry about. We don't have that here. Okay. The last thing we want to do is just open up your mouth really wide. Can you say ah?
Ah.
Good. And we're looking for elevation of the palate. You can also have them cough if you want to. It's the same thing, but we're just checking a couple of cranial nerves, the glossopharyngeal and the vagus nerve here. Okay, everything's looking good. We're done with the mouth. Okay, so the last part of the HEENT exam is actually the throat. And before we actually examine the anatomical structures in the throat, like the thyroid and some of the cartilage there, we can first show you the lymph nodes that you're supposed to test throughout this whole region, starting at the top of the chin. So this one's called the submental lymph node. And then along below the mandible is submandibular lymph nodes. And then the parotid or tonsillar lymph nodes, you can kind of feel from this region here. Preauricular and postauricular in front of and behind the ears, right here. Occipital lymph nodes at the very back of the cranium at the occiput. Okay, and then we have superficial cervical lymph nodes along the front of the sternocleidomastoid muscle. Okay, deep cervical lymph nodes, they're in the anterior triangle, which is this region in between the sternocleidomastoid and the median line of the throat here. So this is the anterior triangle. Feeling for the deep cervical lymph nodes, basically you're hugging the carotid and the jugular veins here, internal jugular. Okay, and you can't normally feel these, but you would feel a node, a nodule or something if there was an abnormality. Also, we have the posterior cervical lymph nodes in the posterior triangle of the neck. This is the region between the sternocleidomastoid and the trapezius muscle. It's this region here, and you can sometimes feel a nodule if there is an abnormality there. And while I'm actually thinking of it, when you're properly palpating for a lymph node, some people try to do what's called piano fingers, where they're sort of tapping, feeling like this along a structure. And this is very ineffective at actually appreciating differences in size of lymph nodes. So what you want to instead do is almost massage the surface of the skin, and this can really help you delineate the size, the true nature of the nodule, if there is one. Okay. So anyway, the last one we want to show you is the supraclavicular lymph nodes, just along at the midline of the clavicle, right here. And actually on the left side, this is called Virchow's node, and just FYI, if there's stomach cancer, something that is metastasized or migrated. Okay, those are all the lymph nodes. Okay, so now that we're done looking at all the lymph nodes, I'll just show you the normal anatomy and how to assess thyroid in the front of the neck. So the first thing we're going to do is just inspect the neck itself. And to do that, if you could just look up just a little bit. Good. And we're really not looking for anything that isn't subtle. We're looking for pretty much some prominence right below the cricoid cartilage here that would indicate sort of an enlarged thyroid called a goiter. But other things you should be able to just appreciate through normal inspection. Once we're done with that, we can then palpate, and we're pretty much just checking for normal movement of the neck. We're also checking for the normal anatomy. So in this case, the thyroid cartilage and the cricoid cartilage just below it. Okay. Any tenderness?
Mm-mm.
Okay. Good. The last part is checking the thyroid, and to do that, what you're going to have to do is get behind the patient, put your hands around their neck, and start feeling the thyroid just below the cricoid cartilage. But because we're wrapping our hands around their neck, you want to tell them first what you're about to do. So Erin, I'm going to be coming behind you. If you could please swing your legs just to the side a little bit. And I'm going to put my hands around your neck, and I'm just feeling for the thyroid just below this prominence in your throat.
Okay.
In my throat, but you don't have as much of one. Okay, so what I'm going to do, placing my hands between the cricoid cartilage and the sternal notch right here. Now, Erin, we have a cup of water here for you. Would you mind taking a sip of your water and swallowing? Good. And as she swallows, this actually causes the throat, the esophagus, to elevate the thyroid gland. And in this case, you should be able to feel that slip beneath your fingers on either side, both the right and the left thyroid gland, and you can also feel the isthmus of the thyroid right at the midline. And that's pretty much it. So this concludes the HEENT exam. There are a lot of components to it, but with enough practice, it shouldn't take very long. At this point, though, you should thank the patient for their time, ask them if they have any questions, and then basically tell them that you're going to go discuss the results with the healthcare team, and you'll be back with them shortly.